Welcome back to Ask the Expert, where we break down the science behind bleeding disorders and the treatments changing lives. My name is Amy Board. I am your host, and today we're diving into a topic that hasn't had nearly enough attention: women and bleeding disorders. For too long, women with hemophilia or von Willebrand's disease have been dismissed, misdiagnosed, or excluded from research altogether. Heavy menstrual bleeding just brushed off as normal, iron deficiency overlooked, and women labeled as just carriers instead of patients in need of care. But here's what's changing. We now know bleeding disorders aren't gender specific, and with rebalancing agents and other emerging therapies, we're not just talking about replacing missing factor anymore. We're talking about restoring balance. And that shift opens new possibilities for people with rare bleeding disorders, those with inhibitors, and for women, who have often been left unheard. This time, these voices can shape the future from the very beginning. Today, we're going to break down the science, hear the stories, and talk through the systematic gap that still exists.
Kevin lives with hemophilia A. He enjoys hanging out with friends, cooking, and playing guitar. But what you don't see is how living with hemophilia has impacted his communication style. Kevin bravely shares the hurdles he faced in communicating about his hemophilia with friends, family, and providers, and highlights the importance of transparent, patient-focused conversations that go beyond treating symptoms. Scan the QR code or click the link in the show notes to hear Kevin's full story and learn more about how living with hemophilia can impact communication.
Now, when we talk about bleeding disorders, the spotlight has almost always been on men with hemophilia. But what about the women? Too often their symptoms are minimized or worse, normalized. Imagine showing up with a bleed that lasts for 19 days and being told that's just what happens every month. It doesn't quite add up, does it? So today we're checking in with our usual experts, and we're excited for a new voice that's joining us. Dr. Janice Stabler, Associate Professor of Pediatrics at Hematology and Oncology from the University of Iowa. To begin, I asked Dr. Mark Redding just how many women were actually involved in the clinical trials for rebalancing agents.
Some, but not enough. Women weren't intentionally excluded from all these trials, but the number of women in these studies is definitely not a high enough number. We would desperately like to see more women included. And that's something, hopefully in the real world experience, we'll get that. Part of the reason there's just fewer women that have the severe enough form of the condition to qualify for the clinical trial. I'm glad you brought this up. I mean, this is a super important topic. We have for many, many years not paid enough attention to the women in our community, and it's not okay. And we're doing what we can to fix that.
So not exactly the answer we hoped for. Some, but not nearly enough. And this isn't just an oversight. It's how trials have been traditionally designed, focusing on men. So of course, I also asked Dr. Ellsworth the same question.
Not enough. It's hard. You know, I've done some of these like kind of consultations and stuff with companies, and it was about an unrelated topic, but this came up, you know, like, oh, well, you know, who else could use this? And I'm like, women with von Willebrand disease, you know, women with mild hemophilia, moderate, even severe, you know, but I have a lot of women with mild hemophilia who have heavy menstrual bleeding and are afraid to have babies and are afraid of how that's going to look because of their bleeding.
That gap Dr. Ellsworth describes, women living with real fears yet not reflected in research, is exactly what Dr. Janice points to.
I don't think that they are gender specific in their approval. So we'll just start there. And one of the key things for that is that we then could use them in women. Now, what I'll say is that there weren't really women in the clinical trials. When I counsel patients, I try to find something that's like them, like, oh, this kind of looks like you, if you will. You know, I think of it as like the reason why, like in Marvel, there's so many looks to all of the superheroes. Now they've really tried to focus on like what a superhero looks like. So there's, you know, something for everybody, if you will, because if you don't see yourself in that thing, how could you do that? So I always make sure to point out that there weren't women that were studied. And so to have the potential for sex differences is there. So we don't know if there will be more clotting.
So that's why representation matters. Now let's see how the science behind these therapies actually works. So if women haven't been largely represented in trials, including the trials for rebalancing agents, why do they still need access to these therapies? Dr. Ben Samuelson Jones has a great explanation.
I think it's great that women with severe and moderate hemophilia are being included in the trials because there's absolutely no reason that's not the case for non-factor therapies. So I would anticipate and believe that all the non-factor therapies would be available to them. I think severe von Willebrand's deficiency, the rebalancing agents potentially should work for them as well. It's a little different because von Willebrand has so many roles. And so it has the delivery of factor VIII and also this interaction with platelets that's really important. And it's possible that augmenting the coagulation cascade may balance out a platelet problem, but I think that's a little less intuitive. I think there's compelling data. I know there's a company looking at decreasing protein S for Van Willebrand, and I haven't seen their clinical trial data, but their preclinical data is exciting enough that it's moving ahead. And there's no reason that's something that works for decreasing. I mean, maybe there is, but I wouldn't be surprised if something works for protein S decreasing, protein C, and, the other anticoagulants, it could also be effective.
So that's the science way of thinking about it, courtesy of Dr. Samuelson Jones. Now, Dr. Ellsworth has a snackable way to picture it, literally.
Yeah, so on a platelet, there's a few ways you can talk about von Willebrand factor. One is that it's kind of like the jelly between two slices of toast that hold the collagen and a platelet together. So it's stuck to collagen on one side, grabs the platelet with the other, brings them together. But another thing that it does, it also acts as a chaperone sort of for factor VIII, but it's not just in circulation, but actually in bringing it to the platelet surface that von Willebrand factor is important. So factor VIII attached to von Willebrand factor will then be activated, get the von Willebrand factor cut off and put on the platelet by thrombin. So thrombin is sitting there on a platelet surface and kind of acts as this homing beacon saying like, this is where you need to go, cuts off the von Willebrand factor from the factor VIII, puts it there on the platelet surface, and then it gets paired with 9A, and that's where it does its magic.
Essentially, these therapies aren't just replacing factor, they're restoring balance. And for women who experience heavy bleeding month after month, that balance can be life-changing.
So I think there's a few different layers to it. One is that I think there's still, I don't know if I would call it a resistance or just a hesitance, but maybe even just a lack of knowledge in calling, for example, a woman who has one copy of an intron 22 inversion, whatever it is, that gives them 20% factor VIII expression, that not calling them mild hemophilia is a barrier. And so I've been trying to be very vocal at our center, and Alice is too, of saying like, no, they have mild hemophilia. They're not a symptomatic carrier, because that just creates confusion.
Even when the science makes sense, women still face barriers, mislabeling, confusion in the ER, insurance denials.
I had a woman with mild factor IX actually hit her head, go into an ED, and luckily they called us though, but they said, hey, we saw her, it's not so bad, and she's just a carrier, we're going to send her home. I said, no, her factor IX is 18%. You can't just send her home after, getting hit on the head enough that you see this like bruising and a hematoma forming. And so some of it's that it's the language around it, Then once you get an accurate diagnosis, you're saying, okay, this is a woman with mild hemophilia A or moderate hemophilia B or mild B. And you kind of get past that. There still can be a resistance from payers to doing that, either because of previous documentation, prior diagnoses, or them saying like, what are you giving this woman factor for? When we've been able to kind of overcome that pretty regularly. I have a number of people who will just keep factor at home and get it for either like a dermatologic procedure. Like I had one patient who was getting moles biopsied and all this stuff, did not do well with DDAVP. And so we said, well, let's just give you factor. And she started doing that and became independent with factor infusions. And
let's not forget the obvious. Women bleed every month. Menstrual bleeding isn't a side note. It's a critical part of their experience.
There's just been a long history of not including women because of menstrual bleeding. And, and I've gotten the question before, like, well, how are we going to track it? I'm like, well, how do we do it now? We see that these women are iron deficient and miserable and bleeding too much. So like you would track it by seeing, are they still bleeding so much and are they iron deficient? Yeah, that's another population that whether it's a factor VIII mimetic or one of the rebalancing agents that could potentially really be a huge help. And the other thing is just kind of that I think there can be a bit of a sense of, especially if the primary symptom is heavy menstrual bleeding, that it's like, oh, well, it's just what you normally do, but more, like what do you get? But it's like, no, you are creating iron deficiency from blood loss. This is abnormal hemostasis. This is abnormal bleeding. And so some of it, I think, is just people kind of minimizing the bleeding that a lot of women with bleeding disorders experience in the first place. And I think that's where STAR with this VGA protein S antibody is hoping, at least that's the impression I've had. Maybe that's just my own like opinion from seeing their data presented, but I think that's where they're looking to for things, is seeing, can we help heavy menstrual bleeding in people with von Willebrand disease?
Science is one thing, coverage is another. Even the most promising therapies can hit a brick wall when it comes to insurance.
Along those lines, I've known a number of colleagues who have used like emicizumab, for example, for bleeding prophylaxis for heavy menstrual bleeding, which I think is great. And I've tried it twice and just really gotten shot down by payers. And I've tried and I'm going to keep trying. But that's another area where I think, especially with these newer ones, until we get more experience and data, because there's probably not, at least anytime soon, for example, going to be a trial with like this VGA 039 saying for this specific indication, so it's like, what do we do in the meantime and until that's there? And I think it's, you just kind of keep bugging insurance companies and trying to get payers to do it. And hopefully as people get more experience with it, they publish it so that we can then say in these so-called peer reviews, like, hey, look, there's data, people are doing this and it's okay.
The good news? Advances in therapy are giving us opportunities to close these gaps, moving beyond only treating severe hemophilia in men and finally recognizing mild, moderate, and female patients who deserve the same attention.
We're starting to recognize that people with non-severe hemophilia maybe should be on some of these prophylactic therapies that we now have. We know that they bleed, they just don't bleed as often and as easily as people with more severe hemophilia, but it isn't like they don't bleed.
So finally, we're shining a spotlight on those who have been in the shadows: mild patients, moderate patients, and women with hemophilia.
We now have an opportunity to really focus and provide better care, I think, for a lot of those patients. And that includes people who don't have a Y chromosome. So that includes all the XXs out there and all the XYs out there. Those of us who are living, with hemophilia, we now have an opportunity to address it, I think, across the board. So really a phenomenal opportunity to do what we do best. And there is no shortage of need and no shortage of work.
That's why we're now considering everyone, not just the traditional trial participants, and why embracing variability in clinical studies is essential.
We have tended to sort of not think about non-severe hemophilia folks in these clinical trials. If you had a factor level of 3 or 4%, there was a time when we'd say, oh man, you're so lucky you've got mild hemophilia. I mean, technically it's moderate, but most of those folks weren't on prophy. The reason for that is because the drugs we had for prophy before all these new drugs, we couldn't get factor levels, trough level that high. And so they were better off than the best we could do with the tools that we had, 20, 30 years ago. That is really changing. These new drugs work much better, and the degree of clotting ability that they give you is much higher than what we had with the original factor medicines. And so now when I see somebody with a factor level of 3 or 4%, that person isn't doing better than a lot of the patients with severe hemophilia who are on these new drugs. These drugs work that much better. So the bar has gotten a lot higher. So the severity of your hemophilia that sort of prompts us to think, hey, this person should be on prophylaxis, that bar has gotten a lot higher because we have much better tools than we used to have. So we don't have as much data in those people because they weren't included in the clinical trials. And so that's another group that we need to pay more attention to and learn more about. And I think we will. I think we will start seeing people with non-severe hemophilia being treated with these medications because they bleed too.
So how do we take all this new knowledge and actually change the game for everyone? Dr. Redding breaks it down for us.
We have to sort of articulate the need for that. One part of our job, I think, is to be very vocal about where we have gaps in our knowledge. We have to sort of say, hey, here's a group of people that's part of our community that we haven't paid enough attention to that need more attention. We need to do more work to help make sure that they're getting the best treatment we have. So that's part of it. One of the challenges, though, in developing those studies is that when you start to look at mild and moderate hemophilia and including women, the numbers are smaller and the variability is higher. So the patients have varying degrees of bleeding tendency and they're not all exactly the same. And so when you do a clinical trial, you want all the people in the trial to look as much alike as possible so that you can really focus on how the drug is working. You want to try to eliminate as many other variables as you possibly can. So you want all the patients to be about the same age and you want them to all be about the same baseline health status. They all have to have the same baseline bleeding tendency so that you can figure out how does a drug work, and all those other variables kind of get canceled out. When you start thinking about non-severe hemophilia, the variability from patient to patient in terms of bleeding tendency is a lot greater. And so it's harder to find large enough numbers of people that look enough alike to generate the same sort of data that we'd like to see to get drugs approved.
The takeaway? Women have been overlooked for too long. Mild and moderate hemophilia just flew under the radar. Heavy periods were dismissed. Trials focused on men. But things are changing. Experts are listening. Therapies are evolving. And women are finally being included from the start.
We're going to have to get over that. We're going to have to sort of get better at accepting that there's going to be more variability, if we're going to understand how to use these drugs in populations that just have more variability in their clinical status.
And as Dr. Redding reminded us, it's time to embrace the natural variability in patients, the differences in how bleeding disorders show up in each person, and adapt our studies so that everyone, not just men with severe hemophilia, can benefit from advances in care.
Health equity starts with understanding. Sanofi's global survey of 2,700 participants across 11 countries uncovers critical care gaps for people with hemophilia. Only 30% of patients report adequate care, and just 21% discuss overall health with providers, highlighting inequities in comprehensive care. Furthermore, 59% of caregivers face significant strain, proving unmet needs go beyond patients. Addressing these disparities is essential for equity. Scan the QR code or click the link in the show notes to explore the findings and learn how Sanofi is building a more equitable future for the hemophilia community.
We hope today's episode shined a light on these challenges, the science, but most important, the opportunities ahead. Remember, this isn't just a story about medicine. It's about being seen, about being heard, and getting the care you deserve. Thanks so much for joining us here on Ask the Expert. Keep asking questions, keep listening, and keep advocating, because every voice matters. Until next time, stay curious, stay kind, and we'll see you back here soon. Did you know bloodstreammedia.com is your one-stop shop for all podcasts for the bleeding disorders and rare disease community? There, you can find links to the Global Hemophilia Report and our flagship podcast, Bloodstream, with your hosts, me and Patrick James Lynch. Also, check out Flow, which is straight talk about extreme periods, and The Pain Pod, which is an in-depth storytelling odyssey of chronic pain. All this and more on bloodstreammedia.com, the #1 podcast network for rare disease. Have an idea for a future episode of Ask the Expert? Or have a question that you would like to hear one of our experts answer? Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream Media on Facebook and on Twitter and on Instagram and all those social media channels. I am your host, Amy Board, and until next time, stay curious, my friends.